Good day, doctors. Before viewing this month's online CPD session, please make sure you answer the pretest to assess if there is enhancement of your clinical skills for this topic. Hi, I'm Dr. Maricel Pulhinda Cumos, a member of Philippine Pediatric Society, Southern Tagalog Chapter, and a developmental and behavioral pediatrician. Welcome to our March CPD Online on Down syndrome, entitled My X and Y's. People with Down syndrome should not be seen as different, but as people who happen to have some additional needs. The outline of my talk includes the following objectives. First is to detect Down syndrome in context with its presenting features. Second, to properly promote health among children with Down syndrome. And finally, to provide medical and social assistance and educate parents and guardians regarding Down syndrome. As we all know, Down syndrome is the most common autosomal trisomy and the most common identifiable cause of intellectual disability. It has a natural prevalence of 1 in every 700 live births, with a decline in the incidence from 1.33 in every 1,000 to 0.92 in every 1,000 due to prenatal screening. In the latest data of DISAPI or Down syndrome in the Philippines, there are about 1 in every 800 or 1,475 new cases per year. So what is the cause of Down syndrome? Down syndrome is a common condition caused by having extra copies of genes on the 21st chromosome. Those extra genes change development during pregnancy, and they continue to have effects after birth and throughout a person's life. It is usually caused by an error in a cell division called nondisjunction. This is when the baby has 3 number 21 chromosomes instead of 2. So let me discuss the 3 genetic variations, which include trisomy 21, translocation, and mosaicisms. More than 90% of Down syndrome cases are caused by trisomy 21. It is when the egg and the sperm unite to form the fertilized egg. 3 rather than 2 chromosomes 21 are present. For translocation trisomy 21, which is seen sometimes in 3 to 4% of cases, part of chromosome 21 becomes attached or translocated to another chromosome, which is usually the 13th, 14th, or 15th chromosome before or after conception. Mosaic trisomy 21 is a rare form with less than 2% of cases of Down syndrome. While similar to simple trisomy 21, the difference is that the extra chromosome 21 is present in some, but not all cells of the individual. This type of Down syndrome is caused by abnormal cell division after fertilization. Usually, Down syndrome will be suspected at birth or in the newborn period. In this case, the pediatrician should be involved immediately in giving the details on the variety of physical characteristics that together indicate the consideration of the diagnosis. So let me give you some of the most common diagnostic features of Down syndrome. The facial appearance of the child is often the first clue. Upslanting palpebral fissures, brush-filled spots, and epicanthal folds are the more common features of the eyes. Other common facial appearance include nuchal fat pad, depressed nasal bridge, and brachycephaly, flat facial profile, and small ears. In the extremities, findings commonly seen include white gap between the toes, clinodactyly, and single palmar crease. However, the definitive diagnostic procedure is chromosomal karyotyping. After confirming the diagnosis, there are several comorbid conditions which may occur with sufficient frequency that an organized approach to medical management is indicated. The American Academy of Pediatrics has developed medical guidelines on these conditions. In the following discussion, I will be giving you information on some of the most common comorbid conditions and the corresponding AAP recommendations on health supervision that every pediatrician should be aware of. Congenital heart disease has been estimated in 50% of children with Down syndrome. A pediatric cardiologist should evaluate as soon as diagnosis is made, and echocardiogram could be done at birth to 1 month of age. If with congenital heart disease, monitoring for possible congestive heart failure be done. There's also an increased incidence of congenital gastrointestinal malformation such as duodenal atresia and imperforate anus, which occurs in 5% of cases. Physical examination should be done at birth. Children with Down syndrome present with mid-facial hypoplasia. Hence, they are at increased risk to recurrent otitis media, nasopharyngitis, or sinusitis. Hearing impairment affects 38 to 78% of individuals with Down syndrome, and otitis media is a frequent problem, affecting 50 to 70% of Down syndrome children. Optimal hearing should be ensured to avoid difficulties in expressive language development. As pediatricians, we have to ensure that newborn hearing screen is completed, and hearing should be evaluated regularly throughout the childhood. Ophthalmologic difficulties are also common, so it is important to ensure optimal visual function. Refractive errors occur in 50% of children. Hence, routine evaluation is indicated with the following pediatric referral recommendations. Eye exam at birth to 1 month to check for cataracts. 1 month to 1 year to detect strabismus, nystagmus, and cataracts. Annual check-up at 1 to 5 years old, every 2 years at 5 to 13 years old, and every 3 years at 13 to 21 years of age. Children with Down syndrome also have a variety of sleep abnormalities. The midfacial hypoplasia plus hypotonia contribute to an increased risk for obstructive sleep apnea. Assessment should be made beginning at 1 year of age with a recent recommendation of AAP that sleep study or polysomnogram should be done at 4 years of age. Hematologic disorders are also common, like polycythemia, macrocytosis, transient myeloproliferative disorder, and childhood leukemia. Please look at the updated AAP recommendations for hematologic disorders. Hypothyroidism is found in 50% of children with Down syndrome. Thyroid supplementation leads to an increase in motor development, length, and weight. Thyroid testing should be done in the newborn period with repeat screening at 6 and 12 months of age and annually thereafter. Height and weight should be measured periodically. There's an increased prevalence of orthopedic problems due to abnormally loose ligaments. These include atlantoaxial instability or partial dislocation of the upper spine, patellar instability, and flat feet. Atlantoaxial instability occurs in 10 to 30% and could be asymptomatic in some, which may be a precursor of spinal cord compression. Epilepsy could also occur in 8% of children with Down syndrome, with seizure type that includes the following. By age 40 years, almost all individuals with Down syndrome have characteristic of Alzheimer's disease. Amyloid accumulation in the brain starts in the childhood years, increasing markedly after age 45 years and are associated with the presence of neurofibrillary tangles. There are a number of genes present on chromosome 21 that have been implicated in Alzheimer's disease. The following tables will give you a summary of the most recent health supervision guidelines for children with Down syndrome by the American Academy of Pediatrics. The medical issues for a child with Down syndrome change with age. For this reason, the table presented is divided into several age groups. Each age group includes a list of issues that may be important to your child at that age. The information within each age group is sorted by the parts of the body that are affected. Many tests only need to be done once. Some areas might need to be looked at again or even many times as the child grows to an adult. Please review the following 3 more slides. Pediatricians are in a unique position to identify children at risk because they have regular longitudinal contact with their patients and families. The early identification and prompt referral of children with developmental delays is necessary to provide early intervention services. Early developmental assessment by medical specialists with expertise in assessing delays in developments should be done to check for different domains of development. Most new parents have no frame of reference to understand the developmental delays of children with Down syndrome. Parents need to be sensitively educated on what will happen as the child grows. The use of information presented in the following two tables can help pediatricians orient parents on what to expect. Each person with Down syndrome is unique, having some of the many possible health, learning, and related differences that can occur with this condition. So what are the most common developmental delays that we could expect for children with Down syndrome? Infants with Down syndrome typically have central hypotonia and associated delayed gross motor development. Most infants do not sit until 11 months of age or walk until 19 months of age. Motor delay have been attributed to the cerebellar hypoplasia seen in patients with Down syndrome. Down syndrome is characterized by abnormalities in learning, memory, and language that lead to mild to profound impairment in intellectual functioning. Post-mortem observations and MRI studies indicate that people with Down syndrome have reduced brain volumes with disproportionately smaller volumes in frontal and temporal areas and the cerebellum compared with healthy individuals. Down syndrome has been characterized with delay in working memory development relative to nonverbal abilities, whereas visual and spatial processing and memory are their strengths, so that the children learn effectively from visual information. Language and communication skills were also delayed in children with Down syndrome due to small muscles in the tongue, face, and throat. Hence, it is much more difficult for children with Down syndrome to form words for other people to understand. Early intervention programs represent a wide array of developmentally based therapies being used with children with developmental problems during infancy and preschool. Early intervention programs usually involve therapists and special educators whose goal is to help the baby develop motor skills, language, social skills, and self-help skills. First intervention that we should consider is physical therapy that focuses on motor development. The goal of physical therapy is to teach the children with Down syndrome to move their bodies in appropriate ways and to improve their muscle tone. We also have occupational therapy, which focuses on child's ability to master skills for independence like self-care skills, fine and gross motor skills, and those related to school performance. Although most children with Down syndrome learn to speak and will use speech as their primary means of communication, they will understand language and have the desire to communicate well before they are able to speak. A speech therapist will work with an individual to help them learn to communicate clearly. Another program in the early intervention for children with Down syndrome is education. Optimal environment for learning is inclusion in typical learning environments with therapeutic interventions planned. One of the key issues in education for school-age children with Down syndrome is the need for individualized approach to give opportunities for inclusion for better gains in literacy skills. They have different learning style with difficulty in maintaining of the existing skills. During adolescence to adulthood, appropriateness of school placement should have emphasis on transition planning to adulthood, and adequate vocational training should also be considered. Education should teach independence with hygiene and self-care and encourage opportunities for advancing comprehension of sexuality, especially for girls. The general health and quality of life for people with Down syndrome has improved drastically in recent years. Many adult patients are healthier, live longer, and participate more actively in the society due to early intervention and therapy. In the recent updates given by Bull et al. In the AAP guidance on caring for children with Down syndrome, the group stated that the average lifespan of people with Down syndrome has increased from 25 years in 1983 to 60 years, an increase largely due to improvement in cardiac, hematologic, and endocrine care. The medical and developmental issues for a child with Down syndrome change with age, and the pediatrician plays a vital role in monitoring medical, developmental, and behavioral indicators that may call for additional interventional measures. The pediatrician's role is to confirm the diagnosis and gives relevant information to the parents. Medical assessment should be done at the earliest possible time with further referral as needed. In giving the information to the parents, a pediatrician should have a positive attitude and be knowledgeable to deliver the news once the mother is settled, and preferably both the parents are present. It is important to provide a short description of the physical characteristics, the medical vulnerabilities, and the association with intellectual disability. It is also important to follow the discussion with information that will connect the family to other resources. As a pediatrician, it is important to inform the parents on what to expect from their infant as they are growing up. We have to inform the parents the possible prognosis that it cannot be fully cured and they are not the cause of their child's condition. Genetic referral could be done for genetic counseling. The parents should be advised that they have to provide a nurturing environment to give the child the best chance to reach the full potential. To summarize approach to children with Down syndrome, medical management, home environment, early intervention, education, and vocational training can significantly affect the level of functioning of children and adolescents with Down syndrome and facilitate their transition to adulthood. Support from those who have similar experiences with a Down syndrome child can be very beneficial. Here in the Philippines, we also have local group for families with children with Down syndrome. This year, 2017, Down Syndrome Association of the Philippines, or DSAPI, celebrates its silver anniversary as a local support group which offers immediate help, support, and advice on all aspects of the syndrome. In summary, Down syndrome affects but does not determine development and achievement in a person. People with Down syndrome demonstrate a wide range of capabilities. What happens after birth will be far more important in shaping the outlook for a person with Down syndrome than the occurrence of the extra chromosome at conception. Immense strides have been made in recent years with people who have Down syndrome. Most live with their families, go to mainstream schools, and have various jobs as adults. People with Down syndrome can lead fulfilling lives. Please answer the post-test. Thank you. All for the Filipino child.